I'd like to note in this discussion that we've been weaving a lot of the conversation about some of the toxicities to look for when treating patients with the novel agents. Some of these are agent specific, others like risk for infection are really shared amongst all the treatment. Therefore, learning about these toxicities and how to manage them is really important and can be found across several guidelines. I also want to point out that in this case, the patient had disease progression or resistance to ibrutinib. However, as we're learning across several retrospective studies and clinical trials, resistance to ibrutinib, especially in the frontline setting, is relatively uncommon. Rather, the more common reason for patients to discontinue ibrutinib, including in two large randomized frontline studies, was for intolerance. In other words, development of toxicities where the patient could no longer continue on the therapy. Patients who develop intolerance or a side effect to therapy that can no longer be managed safely for the patient to continue on that treatment still remain an important area of unmet need for patients with CLL. It is very important that we follow the clinical trials that specifically look for agents and for therapies for these patients who develop intolerance. It also is a good reminder that more options of treatment for patients, both in next generation inhibitors to certain targets, as well as different targets entirely, or clinical trials that combine with fixed duration, all of these remain important for our patients. Other areas of unmet need that deserve attention in clinical trials are especially for patients, such as this one in our case, who develop resistance to ibrutinib. We know, though, other targeted therapies can achieve response in these settings, that often these responses, especially if patients don't achieve a complete response or MRD negativity, may not be long-lived and the patient progresses to their next line of therapy. Other options such as cellular therapy, CAR T treatments, and as I mentioned, combination therapies will remain important to try to address these and allow patients with CLL to achieve the best response with the best quality of life for as long as possible. And this, I think, remains and will continue to be what drives us all to continue clinical trials and consider clinical trials for all patients with relapsed or refractory CLL.